If you've been told radiofrequency ablation could quiet your back or neck pain, you've probably also found articles saying it doesn't work. Both of those things can be true, and the difference comes down to one step most people skip. Welcome to the educational channel of Dr. Ryan Kuda, a board-certified interventional pain physician serving the Chicago area. On this channel, we break down the procedures and the research that shape how pain medicine is actually practiced. Today, radiofrequency ablation, often shortened to RFA. A large share of chronic back and neck pain comes from the small facet joints that link the vertebrae together. When those joints become a pain generator, the discomfort can be stubborn, not always helped by medication, and not always a surgical problem. RFA is one of the tools aimed squarely at that kind of pain. Here's the basic idea. The facet joints are fed by tiny sensory nerves called the medial branch nerves. Their job is to carry pain signals from the joint to the brain. Radiofrequency ablation uses a specialized needle, called an electrode, to deliver radiofrequency energy that gently heats a small, precise area of that nerve. That heat interrupts the nerve's ability to transmit the pain signal. The joint itself isn't changed. The messenger is quieted. It's important to be clear about one thing. This is not permanent. The treated nerve gradually regrows over time, which is why relief is measured in months, and why the procedure is often repeated. RFA is typically considered for facet-related pain in the lower back or neck, pain that's been confirmed to come from those joints, and that hasn't responded well enough to more conservative steps like physical therapy or medication. It's also used for some other targets. The knee and the sacroiliac joint have their own versions, which we cover in separate videos. Who is it usually not for? People whose pain is coming from a different source, a disc, a pinched nerve root, or a problem outside the spine, won't benefit from ablating a facet nerve. That's the whole reason the next point matters so much, confirming the pain source first. This is where that opening question comes back. The research on RFA looks contradictory until you look at how patients were selected. The step that separates success from failure is the diagnostic block. Before ablation, the suspected nerves are numbed with a temporary anesthetic injection, a medial branch block, to test whether that's actually the source of the pain. When patients are chosen using strict diagnostic blocks, the published results for facet ablation tend to be more favorable than when they're not. A well-known example of the tension is the MINT trials, published in the journal JAMA in 2017, which concluded RFA added little for chronic low back pain. Professional pain societies pushed back, and a central criticism was the diagnostic block protocol used to select patients. We did a full deep dive on that controversy in a separate episode, linked in the description. The honest summary: radiofrequency ablation is not a cure, and it's not for everyone. But for carefully selected patients with confirmed facet pain, the evidence supports meaningful, temporary relief that can be repeated. Selection is the difference. So what's the procedure itself like? It's an outpatient procedure. You're positioned on a table, the skin is numbed, and the physician uses live X-ray imaging, fluoroscopy, to guide the electrode to the precise nerve target. Before any heat is applied, there's usually a testing step. A small electrical signal checks that the electrode is near the right sensory nerve and a safe distance from nerves that control movement. Once placement is confirmed, the radiofrequency energy is applied for a short time at each target. Most patients feel pressure or warmth rather than sharp pain. The whole thing commonly takes under an hour, and you go home the same day. Because relief comes from the nerve being quieted rather than the joint being repaired, the full benefit isn't always immediate. It can build over a couple of weeks as any procedure-related soreness settles. Recovery is usually straightforward. It's common to have some soreness at the treatment site for a few days, and most people return to their normal routine quickly. As with any procedure that involves a needle, there are risks, and the specific risks that matter depend on your anatomy, your health, and the exact target being treated. That's a conversation to have with a physician who has reviewed your imaging and your history. What the evidence is clear about is the trade-off RFA offers. It's a low-disruption, repeatable option that, in the right patient, can reduce reliance on medication and by months of better function. The key phrase, again, is the right patient. Bottom line: radiofrequency ablation quiets the nerves carrying facet joint pain, temporarily, and only when those joints are genuinely the source. The articles saying it doesn't work and the ones saying it does are usually describing different patients, selected in different ways. If a clinician raises RFA with you, the most useful question to ask is, how will we confirm that these joints are actually causing my pain before we treat them? A reminder before we wrap. This is educational content, not medical advice. Talk to your own doctor about your specific situation. If this was useful, subscribe, and check the description for a deeper look at the medial branch block, the diagnostic test that decides whether ablation is even worth doing.